deficiency of pyridoxine, vitamin B6, you would give that vitamin. Okay. Which mother can give the breastfeeding to her son? Okay, again, a very good question. Direct breastfeeding in HIV, express the milk HIV mother, and then it would give to the child. Direct breastfeeding tuberculous mother, express the milk tuberculous mother. Okay. Yes. What do you think about the answer?
HIV is always contraindicated
HIV is always
for
contraindicated.
breastfeeding.
Very good. And you know,
And
direct
for TB,
breastfeeding for tuberculosis is also prohibited.
nonsense.
Either the mother wear mask while feeding the baby, or the other thing is express the milk and then it would be given to the child. So your answer is expressed milk. Very good. Okay. A patient known case of congestive heart failure and hypertension on ACE inhibitor warfarin was diagnosed with tuberculosis. Started on 4 regimes that we have just discussed. What is your true? Okay. The question is actually when somebody is on the anti-tuberculous drugs, patient is already a known case of congestive heart failure, hypertension and on ACE inhibitor. Okay. What do you think if somebody is on warfarin, which drug should be increased? There would be a drug interaction with the anti-tuberculous drugs. So we need to increase the dose of warfarin. What is the drug interaction? Would the drug interaction between the warfarin and rifampicin, and there would be drug interaction between warfarin and some other drug? Yes. Yes, please. Common sense.
Warfarin and rifampicin.
Warfarin and rifampicin. That's why they have already mentioned. Would you stop the rifampicin or would you increase the dose of warfarin? Actually, there is a close drug interaction between the warfarin. What kind of drug interaction? What do you think, Preetham? Because it would lead to the increased clearance, increased secretion of warfarin out of the body. Okay. So there would be decreased effect of the warfarin on the body. We need to increase the dosage of warfarin to meet the requirement. Clear?
Yes, ma'am. Cleared.
Very good. Okay. Tuberculosis patient, he start to have some pricks in the fingertips, tingling, numbness, vibration, which been increasing. What do you think? Because the patient is having a side effect of INH, vitamin B6 deficiency, so we need to give the pyridoxine, vitamin B6. Non-case of tuberculosis after 3 months of starting ATT, there is an elevation in LFTs. Okay, you know, before starting the anti-tuberculous drugs, what do we need to do? LFTs. Please, before giving anti-tuberculous drug, we have to go for LFTs of the patient. If the LFTs are deranged, then we need to correct those enzymes first and then we'll prescribe. Otherwise, we need to go for another combo of anti-tuberculous drugs. One thing, after starting the anti-tuberculous drugs, you would go for LFTs weekly. When you start the anti-tuberculous drugs, you would check, you would follow the LFTs on weekly basis. Okay. A known case of tuberculosis patient after 3 months of starting anti-tuberculous, now there is elevation in LFTs. What do you do? Would you stop INH or would you stop all ATTs or would you go for any specific drug? What we do, we would stop all ATTs and we would repeat the LFTs after 1 week. I'm repeating again. If somebody on ATT for 3, 4, 5 months, you are having a problem with the LFTs, you would immediately stop all the ATTs and repeat the LFTs. Okay.
Ma'am, why LFTs only, ma'am?
Because all drugs are metabolized in the liver and they are disturbing the metabolic system in the liver, P450 system. That's why there would be
Okay.
markedly increase in the liver enzyme, especially in the ALT, AST level.
Okay, ma'am. Thank you.
And sometimes, if nobody is bothering about the LFTs, in response to ATT, patient would go into fulminant hepatic failure due to these anti-tuberculous drugs.
Yes.
A patient on tuberculosis medication comes for follow-up after 3 weeks and showed abnormal LFTs, negative AFB, resolution of tuberculosis symptoms. What do? We would stop the drug, repeat LFT in a week, as I have mentioned. Okay, stop the drug, repeat LFTs within a week. Tuberculosis patient has increase in uric acid. What is the side effect? Which drug is involved? Parazinamide. It is the side effect of parazinamide, hyperuricemia. Okay. A house worker came from South Africa with bloody cough and X-ray show cavitation. What will you do next? Okay. Now again, South Africa, cough, bloody cough mean hemoptysis. X-ray showing cavitation. First thing that comes in your mind is tuberculosis. What do? What is your gold standard investigation? Sputum culture for AFB. Sputum culture for AFB. Okay. A patient post-tuberculosis bronchiectasis presents with cough, hemoptysis. X-ray show right upper lobe cavity lesion. What is the best initial next step? Now, he is asking about the next initial step, not the confirmatory test, not the appropriate step. Initial step. Would you go for patient placement in the right lateral decubitus position? Would you go for chest physiotherapy? Now see, patient post-tuberculosis has developed bronchiectasis, cough, hemoptysis. X-ray, they show the lesion. First initial step, we would change the position of the patient. We would change the position and then we would go for chest physiotherapy, because chest physiotherapy is the definitive management. And initial management, you would change the patient position, that we usually do in, in OPDs. When we used to do OPD or indoors, we first change the position and then go for chest physiotherapy. Okay. They asked also about the pulmonary hypertension grade 3. We have just discussed yesterday, again showing on right side on your screen. Group 1, exclusive pulmonary hypertension without involvement any other organ. Group 2, pulmonary hypertension due to cardiac problem. Group 3, pulmonary hypertension due to the lung diseases. Group 4, due to thromboembolic events. Group 5, parasitic infection and other hematological disorder. Schistocytosis, sarcoidosis. Okay, so these are the grade 5s or pulmonary hypertension. So pulmonary hypertension grade 3 is due to lung fibrosis or hypoxic lung diseases. Okay, there is an explanation regarding why we are changing the position. If somebody is dyspneic, having hemoptysis post tuberculosis bronchiectasis, because when you change the position regarding of the intubation, because majority of the time the bronchiectasis patient with the effusion, they are with the chest tube in placement. So the patient should be immediately placed in a position when you are suspecting there is a bleeding, or you could see the bleeding is coming, blood is coming in the chest tube. You would immediately change that position to minimize the bleeding. Okay. A patient whose if right lung is bleeding should be placed in right side down decubitus position, and if the left side, vice versa. Okay, tuberculosis patient on the medicines develop paresthesia, again pyridoxine. A type of lung cancer causing superior vena cava obstruction. Okay, you could easily answer this question. We have just discussed yesterday. If there are outlet obstruction, superior vena cava obstruction, a lung cancer, you would think about the non-small cell lung carcinoma. Non-small cell lung carcinoma, because these are the cancer which usually present with these obstructive sign and symptom. Flushing of, hoarseness of voice, Okay, so these are the typical presentation of non-small cell. Okay, what would be the typical presentation of small cell lung carcinoma? We have just discussed yesterday. Yes. Preetham, Noor, Dr. Zahir. Dr. Zahir, how are you feeling now?
My voice is not. I'm unable to speak actually.
Okay.
It's too much sore throat.
Take care first. Okay. Yes. Sayyeda, Noor, Preetham, and Dr. Shakir. Could anybody answer? What would be the typical presentation?
Ma'am, facial blatha and JVP distended.
Yes, please. Who is answering? Yes, please. In the small cell cancer, you would have obviously cough. Okay. That wouldn't respond to bronchodilators and other regimes. Patient would have shortness of breath. Patient would have wheezing. Patient would have hemoptysis. Patient would have difficulty in the swallowing, hoarseness of voice. These are the typical presentation of small cell lung carcinoma. One thing that differentiates it from the non-small cell, that is superior vena cava obstruction. Okay, clear? That's why they have mentioned on the right side, for more than 50% of the cases with the superior vena obstruction, you would first think about the non-small cell lung carcinoma. Okay. A facial plethora, swelling with redness. Okay. JVP distended. Which of the following is associated? Facial swelling, superior vena cava obstruction. One thing. JVP is distended. There are the chances of the failure. That's why the JVP is distended. Which of the following is associated with this condition? Small cell lung carcinoma, non-small cell lung carcinoma. Yes. What would be your answer?
Non-small cell carcinoma.
Yes, the first option is non-small cell. Then you would think about the small cell lung carcinoma. Okay. Case that seemed like obstructive sleep apnea. Okay. Now we have discussed already the obstructive sleep apnea. The most common cause are obesity, morbidity, obese, BMI more than 30, patient who have a problem of thyroid like hypothyroidism. Patient usually present with the apneic episode during the sleep, during driving, or during any activity. There is a large snoring. Okay, patient could have cyanosis. One thing. How would you investigate? Polysomnographic sleep study. Polysomnographic sleep study. What is the management? CPAP. Continuous positive air pressure ventilation. CPAP. When would you prescribe BiPAP? Yes, my students. When would you advise BiPAP? Yes, please, BiPAP.
There is respiratory failure, ma'am.
Yes, in case of respiratory failure, when there is, there is a tie between invasive mechanical ventilation and non-invasive mechanical ventilation. BiPAP is non-invasive mechanical ventilation, and invasive ventilation is intubation ventilator. One thing. BiPAP, when somebody is alert with the sign and symptom of respiratory failure, then we would shift the patient for the BiPAP. If somebody is having respiratory acidosis, his conscious level is deteriorated, or patient is having chest full of secretion, ABGs are deranged, then you would shift the patient for the invasive mechanical ventilation. Okay. A patient with rheumatoid arthritis has increasing shortness of breath and dry cough, cyanosis, clubbing, Bibasal fine crepitations. Okay, these are the typical symptom of interstitial fibrosis, pulmonary fibrosis. Why? One thing, if non-case of rheumatoid arthritis become shortness of breath, having a problem of cough, now having a problem of bluish discoloration of the skin. On examination, clubbing is positive and fine basal crepulation. So idiopathic pulmonary fibrosis. Your diagnosis would be idiopathic pulmonary fibrosis. Would it be restrictive lung disease or obstructive?
Restrictive.
Yes, restrictive. Very good. And how do we investigate? Again, through spirometry. What would you see on the spirometry? If FEV1 and FVC ratio in restrictive lung disease, FEV1 would be normal or slightly low. And what would happen to FVC? FVC ratio would be normal. That's why the ratio of FEV1 and FVC would be either normal or high. And in all obstructive lung diseases, this ratio is below 80%. This ratio is below 80%. So in restrictive, it would be more than 80%, the ratio. Okay. We have already discussed that total lung capacity would be normal or high in obstructive lung diseases. But in case of restrictive lung diseases, all the capacities would be remarkably low. Total lung capacity, vital capacity would be very low. Clear? Am I clear?
Yes, yes.
Okay. Patient has restrictive pattern. Diagnosis is lung fibrosis. Okay. And this fibrosis would be post-inflammation like rheumatoid arthritis, like other inflammatory condition, for example, pneumonia. So these could all lead to fibrosis. 40 years old patient came to ER complaining of shortness of breath. He has a history of cigarette smoking, 20 packs per day, but otherwise well. Spirometry show a restrictive pattern. Diagnosis, fibrosis, pulmonary fibrosis. Neonatal get pneumonia. Type of pneumonia. Okay, immunity, sorry. A neonatal get pneumonia. Type of immunity. Active natural immunity, passive natural immunity. What would be the type of immunity? Okay, I'm sure you guys have very good idea about the immunity. It is innate and acquired. Acquired is further divided into active and passive. Yes, and active immunity when we give the injectables to the like EPI, these kind of things. Okay.
Vaccine.
And in case of
Vaccine.
passive immunity, when somebody is, yes, Sayeda, are you sharing something?
The active. No, means active immunity means vaccine.
Yes,
Vaccine is
vaccination,
always active.
like EPI and other kind of vaccination that we receive. Very good. That is artificial.
Yes. Yeah.
And natural is,
For artificial.
and natural is,
Natural means the skin, mucus secretion.
when somebody get
all are
infected
innate.
against any agent and body start developing antibodies, that is natural. Okay. Now the
Yes.
passive immunity. The passive immunity, like mother through the breastfeeding transfer the antibodies. Okay. Through the circulation transferring, that is natural. Artificial, when you, what, can you give me an example of passive
Immunoglobulin.
artificial?
Immunoglobulin.
Very good. Excellent. Very good. Okay. So, okay. Smoker since 20 years presented with dry cough and shortness of breath. Dry cough and shortness of breath. They would definitely mentioning about the spirometry pattern, one thing, or it could, they could mention that there is a restrictive pattern on the spirometry. Then your diagnosis would be interstitial fibrosis. Superior vena cava syndrome, most common caused with lung cancer. More than 50% non-small cell lung carcinoma. in case of superior vena cava obstruction. Small lung carcinoma. Small lung carcinoma, when the student is saying, I forget he has pain or not. Okay. He will die before 1 year. Calcium level is 3.5 millimole. That is absolutely normal. Okay. Sorry. He will die before 1 year. Calcium level is 3.5. The normal range is 1.1. What you will do for him? Okay. Just think about patient is having small lung carcinoma. One thing. On investigation, there is hypercalcemia. There is hypercalcemia. What first thing comes in your mind? Diagnosis already mentioned, small lung carcinoma. Hypercalcemia. Why there is hypercalcemia? Why there is hypercalcemia?
Hypercalcemia means you said that parathyroid like secretion
Very good.
is
Very
occurring in
good.
small cell. So the calcium level is increased.
Very
So
good.
the
Very good.
hypercalcemia.
And other thing, you know, this is an advanced stage. Why they are mentioning the patient would die within a year. Okay. Because this time the patient is having tumor lysis syndrome. Tumor lysis syndrome that would release the minerals. For example, one is calcium in response to parathyroid hormone like peptides, which is responsible for this hypercalcemia, and other chemicals as well. What do? Whenever you find a patient, even the patient is having cancer or not, the one investigation, hypercalcemia, you would definitely rehydrate that patient, because post chemotherapy you would see the hypercalcemia. Patient would have a problem of dry mouth. There would a difficulty in the speech post chemo radiation therapy, because there are the sign and symptom of tumor lysis syndrome with hypercalcemia. And the best management is rehydration. Rehydration with what? IV normal saline. IV normal saline. Again repeating, when somebody is dehydrated, you would rehydrate the patient with the bolus IV normal saline. Most common lung carcinoma causes superior vena cava obstruction. Again, non-small cell lung carcinoma. Okay. Small lung carcinoma complaining of the back pain for 12 hours. Neurological examination is normal. What most appropriate next step you would go for? MRI spine, steroids, MRI plus IV steroids, and no need of urgent management. Number one. Small cell lung carcinoma, backache for 12 hours. Neurological examination is normal. What do? We'll have to go for back pain. You would treat that back pain with what? With IV steroid. And we would definitely recommend the MRI just to see for the metastatic extension. Clear? Because the patient is now, the most common site of metastasis for lung cancer is bone. And for the bony pain, we do have in our mind the patient has metastasis. That's why he's complaining with the backache. So we would prescribe steroid and then we go for MRI just to have a look about the extent of metastasis. A scenario of elderly patient who had chest infection 4 weeks ago, initially improved on antibiotic, now worsened again. X-ray show right pleural effusion. Now, just discussed yesterday, if the pneumonia remains untreated, it would lead to effusion, and that is known as parapneumonic effusion. Primary prevention of tuberculosis, vaccination. Primary prevention is vaccination. A case about a patient with pleural effusion and ask about the most accurate management. Sputum for AFB culture. Sputum for AFB. Okay. Okay. See, this is my exam question. Look at the level of adenosine deaminase level. This is another gold standard. If your scenario is not mentioning about the sputum culture, and there are other options including adenosine deaminase, Look at the level. If the level is more than 50 microgram, then the patient is tuberculosis positive. Again, saying if adenosine deaminase level is more than 50 microgram per liter, it means the patient is positive for tuberculosis. Okay. Pneumonia symptom with medium pleural effusion, parapneumonic effusion. What is the indication? Already discussed. Okay, that's why I'm skipping. pH level less than 7.2, glucose less than 60%. Then you would go for thoracosynthesis along with antibiotics. If the pH is more than 7.2 and glucose is more than 60, then only antibiotic. So now the patient is having symptoms plus pleural effusion. A patient with the sign and symptoms of pneumonia, right-sided dullness, if they are saying the stony dull percussion, then we know that is pleural effusion. Decrease air entry, X-ray show middle and lower right lobe consolidation with pleural effusion. Your diagnosis is parapneumonic effusion. If somebody pH, that pleural fluid pH is less than 7.2, glucose is less than 60%, you would prescribe the antibiotic plus thoracosynthesis. Where would you pass this tube? What is the area, location for thoracosynthesis? Yes.
Second, third intercostal space.
Very good. 9 intercostal space in the mid
Bloodline.
axillary line. Very good. That would be between the 8th and 10th intercostal space. Good. A patient came with fever, dyspnea, purulent cough, yellow sputum, hemoptysis positive. Examination show marked dullness. Half of the right chest. Decrease air entry on half of the chest. X-ray show consolidation in the middle and the lower lobe. Moderate pleural effusion. What is your best management? Now, fever, dyspnea, purulent cough, plus hemoptysis. Diagnosis is patient is having pneumonia. One thing. Now, X-ray shows consolidation in the middle and the lower lobe with the moderate effusion. So, patient again having parapneumonic effusion. Patient is
Section of
having
pneumonia.
parapneumonic effusion. Then what would you do? Moderate effusion. We would go for antibiotic plus thoracosynthesis because the moderate or severe effusion would compromise your breathing. Patient would have a problem in the breathing. Which of the following pneumoconiosis associated with tuberculosis or predisposed to tuberculosis? Yes. Farmer lung disease, asbestosis, silicosis. Yes. Out of these three risk factors, silicosis is at the top. It increases the chances for the tuberculosis as well as for the malignancy, for the lung cancer, because the patient would markedly become what? Immunocompromised. And what happens to the airways? What happens to the airways in silicosis? Yes, what happens to the airway in silicosis? Although it is
Permanent
also a
bronchoconstriction,
pneumoconiosis disease, yes, please. And it is due to the silicon dust. And if remains untreated, it would lead to the chance for having, yes, lung cancer.
or tuberculosis.
Yes, okay. Because there would be, irreversible scarring of the lung tissue. There would be stiffening. The elasticity would be lost. There would be stiffening and there would be a chances of having lung cancer more. Anti-tuberculous drugs causing hyperuricemia. Which drug is responsible? Parazinamide. Pleural effusion case and high interferon gamma. High interferon gamma, pleural effusion. So that is another criteria for labeling the patient as tuberculosis. Interferon gamma on biochemistry analysis. Okay. Okay. A patient with tuberculosis, X-ray revealed pleural effusion. How to acknowledge the effusion is due to tuberculosis? Again, we know that effusion is exudative. When we label, it is exudate when the LDH level is more than 200, when the glucose is low, when the pH is more than 7.2, exudative for mentioning it as exudative. We know there would be more protein, there would be more polymorpho neutrophils. So we would label it as exudative pleural effusion due to tuberculosis. A middle-aged male complains of shortness of breath, X-ray evidence of pleural effusion, aspiration of fluid to analysis was done. What statement of the following confirms the pleural effusion is exudative? Again, LDH. And what is the gradient? Pleural, fluid, LDH, and serum LDH. It has to be more than 0.6. It has to be more than 0.6. Please remember this. This is very important and it frequently comes in your exam. When would you label the pleural effusion is tuberculous? It is exudative when the ratio between the pleural LDH and serum LDH is more than 0.6. Number one. The pleural fluid protein and the serum protein is more than 0.5. When the pleural fluid LDH and the serum LDH level gradient is high, okay, so you would label it as exudative. Patient suspected tuberculous pleural effusion. What is the sensitive test that support your diagnosis? Sputum for AFB culture. If not mentioned, then look for the adenosine deaminase level. If it is more than 50 microgram per liter, then your diagnosis is confirmatory. Patient was diagnosed with pulmonary tuberculosis, started 4 drugs for the treatment. Now he has a family history of urethral stones. Patient presented with red color urine, okay, with slightly decreased hemoglobin and platelets. What is the possible cause? It is just a side effect of rifampicin that gives the orange or red color discoloration to body secretion. Elderly patient in ER, sign and symptoms of tuberculosis. What is your initial action? First, we would go for isolation because it is an airborne infection. We would go for isolation. Then we would treat the patient accordingly. A patient on anti-tuberculous drug has increased liver enzyme after treatment. What do? Stop the drug, repeat the LFTs. Stop the drugs, please repeat the LFTs. Patient has an X-ray finding a cavity in the upper lung. Whenever you see in this scenario that the X-ray is suggesting there is a cavitative lesion in the apices, in the upper zone, just immediately think about tuberculosis because it commonly involves the apices due to involvement of increased oxygen tension is there in the apices. Okay, so airborne infection, tuberculosis. Long scenario regarding patient with suspecting pulmonary tuberculosis effusion, confirmatory diagnosis. Again, sputum for AFB, culture, 3 culture. TB treatment and the drug cause high LFTs. Stop the drug, repeat the LFTs. Which drug could cause the hepatitis? INH and rifampicin both. Anti-tuberculous drug causing neuropathy, seizures. Yes. Which drug could cause the seizures? Sorry?
Isoniazid.
No, I couldn't hear you. Please
Isoniazid.
speak a bit loud.
Isoniazid.
Isoniazid due to, because the vitamin B deficiency could lead to the seizures. So your answer would be isoniazid. X-ray of apical lesion, cavitative lesion, diagnosis is tuberculosis. Pleural tuberculosis, more sensitivity test. Okay, now this is very interesting question in respect to the statistical analysis. You know what is sensitivity and what is specificity? What is sensitivity? What is specificity? Think about true positive and false positive. Yes, please. The sensitivity is when you label that patient is 100% positive with the disease. That is sensitivity. Positive for the disease. Specificity. Yes, please. What is specificity?
false
That
positive may
when you label that patient is not positive for that disease, patient is negative for that disease, it is not in that area. Clear?
We are not sure at that time.
Sorry?
Yes, ma'am. Okay, clear.
Okay. Now, if somebody
Clear,
is
ma'am.
asking in the scenario, which sensitive test is more useful for diagnosing the tuberculosis, your answer would be ADA, adenosine deaminase level, that has to be more than 50 microgram. Number one, it means the patient is 100% positive for the tuberculosis. If somebody is asking you, what is the diagnostic tool, initial test you would go for tuberculosis patient? We routinely do sputum for AFB. 3 cultures are sent. We used to send in OPDs in indoor patient. Sputum for AFB. That means that would label patient negative, that patient is having disease or not. So, what is the conclusion? The gold standard, the most sensitive test for the tuberculosis, the patient is 100% positive for tuberculosis, adenosine deaminase. This test is a bit expensive. That's why usually in our setup we follow the sputum for AFB. Patient with suspected, I am running short of time, is just less than 1 minute. Okay, is this enough for today?
Yes, miss.
Yes, miss.
I'm become sleepy.
Okay. Okay. Inshallah, tomorrow we will join from here till we are completed with the specificity and the sensitivity. But before starting tomorrow's session, we would quickly just revise. And please mind